policy. And just wanted to welcome you back to the second meeting of the council. Thank you so much for taking the time. I know this is an incredible busy time, especially before the holidays, but really looking forward to the discussion today. And I wanted to turn quickly first to Governor Cooper, who we have here with us today. So, Governor.
Good morning, Amy, and thanks again to everyone who has agreed to serve on this council. This is a diverse, powerful group of people who can make a real difference in the lives of people here in North Carolina. So thank you for the time. People may be coming at this from a different perspective, but I think the idea of this is to find some common principles that we can work toward in the coming weeks and months, particularly when the legislature comes back into session. This has been a historic week with vaccinations starting. Dr. Cohen and I were at UNC hospitals yesterday, and to see the faces of these frontline healthcare workers as they're being vaccinated, it's an amazing thing. And I am so grateful to all of our frontline workers who are having the courage to get in there and to treat COVID-19 patients, both in our hospitals and in our long-term care facilities. There's a lot of reasons for celebration. I was grateful for the White House Task Force and Vice President Pence and his team. Operation Warp Speed was a positive thing and helped to bring these vaccinations to market in a much quicker pace. We also owe a great deal of thanks to North Carolinians who have been involved in coronavirus research for a long time and who took part in clinical trials and who have done so much to bring medicines, therapeutics like remdesivir and others to market, and we're grateful for that. I want to encourage everybody in the meeting to continue to show good examples about prevention, mask wearing, social distancing, washing, and to preach that message. It's so important as we enter into the holidays. And also, I want to add something to that, is encouraging people to get vaccinated when it is their turn. There is some skepticism out there in a number of areas, and I think it's important for strong leaders across the board to talk about the fact that an independent review board of experts with no skin in the game and a very transparent process has reviewed this data to show that this vaccine is indeed safe and effective. We are going to hear today from some of the members in our business community. They are acutely aware that we have about 1.2 million North Carolinians who do not have health insurance coverage. The cost of their coverage is affected by a lot of people who are not covered, because we know a lot of cost shifting goes on back to the business community. So we look forward to hearing from them and their ideas, and a wide range of ideas on how we approach this healthcare coverage and healthcare reform in general. So again, thank you so much for being here. And I enjoyed the meeting 2 weeks ago. I will be not on the entire time, but I'll be on a lot of the time, just like I was last time, to hear what people are saying. And I want to particularly thank legislators from both parties who have agreed to be a part of this. I know we all have the feeling that we want to help the people of North Carolina, and we want North Carolinians to get quality health care. And hopefully together over the next few weeks and months, we can find a way to make sure we do that. So thanks for letting me be on, and look forward to a good meeting.
Thank you so much, Governor. I wanted to take a moment to turn to Secretary Cohen.
Good morning, everyone. I'll be incredibly quick. I just wanted to thank everyone for the work that has gone on in between meetings. I know we're having these meetings every 2 weeks, and I just appreciate the engagement even between meetings. You're going to hear from a number of council members today, and that was truly the intent, is to make sure that we're hearing from all perspectives and getting all ideas related to coverage out on the table. So I'm really excited for the grid discussion. I want to thank the Duke-Margolis Center again for facilitating and helping us make sure that we're bringing all good ideas to the table. But thank you for the ongoing engaged work. And I hope this will be a very active discussion meeting, but there's so much to cover. So let's just dive right in. Thank you, Amy.
All right, great. Thanks, Mandy. So wanted to just take a moment to talk a little bit about what we're going to do today. It's wonderful to see all your faces back here after just 2 weeks. We were together. So one of the things we're going to do first is just quickly review the mission of the council, some information about the uninsured population, and then, you all got a survey from us earlier this week, and we wanted to just review the results of that survey, which was really about what are your top priorities for increasing healthcare coverage in North Carolina, and what else do you want to hear about? We really took to heart the comments from the last meeting about the different ideas that you wanted to discuss today. So following just that very quick presentation, we were going to hear from the employers. That was a priority from last meeting, to hear about what they think should be some things that this council should consider with respect to coverage. We're also going to hear about other ideas that can impact the insurance market, which includes reinsurance programs and association health plans, and expanding coverage for pregnant women and postpartum women and parents of foster children. And then we are going to spend some time talking about increasing access to and coverage of behavioral health services, because that was also a topic that was much discussed in our last meeting. And then we will talk about next steps. So I wanted to just make sure that you knew the rundown for the day. And as last meeting went, really encourage active participation. This should be a dialogue. This is a place for you all to share ideas with one another. So please use the chat function during presentations to just share ideas or share questions, and I will do my best to make sure I see all of you who want to chime in and add to the discussion to make sure that everybody has a chance to speak. So again, really encourage that robust dialogue. So we'll just dive right into it. We have a lot to cover today. So next slide, please. Okay, so just wanted to really briefly talk about the mission of this council. And in the materials for this meeting, you received the mission statement. As Governor Cooper said, there are 1.2 million uninsured residents in North Carolina. So one of the goals of this and charge of this council is to really review the state of healthcare coverage in North Carolina. Think through how other states have increased access to healthcare coverage, learn from one another in terms of what are the best ideas that you all want to share as a group, and then develop a set of principles to guide policymakers to increase coverage in the state. So that's the overall mission. And with respect to the summary and guiding principles, we're going to talk a little bit about this at the end of this meeting, but you all will really be engaged in a process as a group to really recommend guiding principles around coverage. And what we're going to do is we're going to give you a little bit of homework at the end of this meeting and follow up in between this meeting and the third meeting to think about what are the best ideas you want to bring to the table with respect to high level principles about what North Carolina should be thinking about on coverage. In our third meeting, which will be on January 8th, we will be thinking about breaking you out into working groups to talk a little bit more about these ideas. So between this meeting and next meeting, you can do some creative thinking over the holidays, and we'll send you some materials, and then we will come back together on the 8th to talk a little bit more purposefully about what could some guiding principles be. And as you all discuss that and develop them, at the end of all of this, a report will be prepared and drafted, shared with you all, and then posted out publicly. So just wanted to outline the goals of this council to make sure that was clear to everybody participating. Next slide, please. Next slide. Waiting for this. There we go. So just wanted to briefly talk about, and we talked a little bit about this last meeting, and we're going to have a lot of great different ideas brought to the table, but just at a quick snapshot, just talk a little bit about who is uninsured in North Carolina, just to remind everyone, this is the population we're going to be talking about today. There's 1.2 million uninsured in North Carolina. As you can see by this data, lower income folks are more likely to be uninsured. So, 24.3% of the uninsured have their income is at less than 50% of the federal poverty level, which translates to $0 to $6,380 a year per individual. And you can see across the graph, I won't read all of these, but the vast majority of individuals are below 200% of the federal poverty level, which means they're at an individual level under $225,000 a year about. So that's the population that is predominantly uninsured in North Carolina. Next slide, please. This was also some data that was shared, but I know so much data was shared last meeting, so I thought it was worth revisiting. Just looking at which industries where people are working and do not have insurance, just to pull out a few examples. Again, I won't read this whole slide. You'll have this as a resource. You can see that hotel and lodging workers have a 28% of uninsured rate, so fairly high. Restaurant workers at the same level as well. And then right behind that are, people who work in child daycare centers, as well as hair cutters, which are at 20%. So I think it's just to give you a snapshot of, those who are uninsured and who are working, what are some of the industries where that's happening. And then just a little bit more data on who the uninsured is in North Carolina. So you can see across this, again, I won't read this whole slide, you'll have it as a resource. A couple of things, there's certainly some veterans in the mix here, and that came out actually in some of the survey responses that we received. There's 30,000 veterans who are uninsured in North Carolina. There is folks who are employed. You can see here 66% of the uninsured are employed. And as I mentioned in the last slide, high insurance rates are in hospitality, retail, and manufacturing. And then you can see the age breakdown and race and ethnicity and families and children. So there's certainly people across all of those different categories that are uninsured. Okay, next slide, please. So thank you for those of you who responded to the survey. I know you didn't have that much time. We got about 20 responses. So if there was anyone who did not respond to the survey and still has interest, please go ahead and send us those responses. We will continue to include them in our summaries. Elaine Sheehan, who's on this call, sent out the survey, and she would be happy to follow up with you with any responses that you have. So the survey remains open is all I wanted to say. But for those of you that responded, thank you. And I just wanted to highlight what really came across in the responses. The majority of the responses really addressed increased coverage and access for these groups of folks: children, mothers and pregnant women, parents of foster children, rural areas, substance use disorder, mental health services, the uninsured and underinsured, veterans ineligible for VA benefits, and essential workers. And there was actually a number of folks that talked about rural in particular. So that is something that definitely should be a topic that the council thinks more carefully about. But there were a number of other priorities and interest areas, and just here they are in the slide, reducing disparities in coverage, closing the coverage gap. Some did mention Medicaid expansion, state innovation waivers, which we are going to talk about today, association health plans, which we are also going to talk about today, provider solvency and stability, support for safety net providers, access to quality care, telehealth, access tax credits for small business to provide coverage, and state subsidies for purchasing exchange plan coverage. So really wonderful list, and I think it reflects the diversity and expertise that we have on this council. So thank you for really sharing all those ideas. One note, you can see based on the agenda, we're packing in a lot of content today, and a lot of it tracks to what you all responded to on your survey. So we really hope we can continue to make sure that these meetings are reflecting what you all want to talk about. Okay, next slide, please. And then you also listed options that you wanted to make sure the council learns about. I won't read the whole slide, but you can see a lot of these came up yesterday. Some of these we'll be talking about today, which was the association health plans and state reinsurance plans, and the expanding access to rural areas was another one that a couple of folks really thought would be important. So lots of, I think, good things to continue to talk about here at this meeting and the subsequent meeting that we're going to have on January 8th. Okay. All right, so that's all I had. Before I moved on to the next section, I wanted to just pause for a moment and see if anyone had thoughts or reflections about anything that was just discussed. Feel free to just chime in if you have anything to share. Oh, Patrick Woody, go ahead.
Yes, this is
Yeah.
Patrick. And I typed a note in the chat box, but as I looked at the sectors as you described, where the coverage gap really exists in terms of business sectors, that directly correlates to what we see with our rapid recovery loan program that we manage on behalf of Golden Leaf and the state. Those sectors, there's just direct correlation. And I just think that bears pointing out that the pain the small business sector is feeling is the same sectors that are affected by the coverage gap.
Thank you. That's a really important point. Other comments or thoughts? Oh, yes, go ahead, Representative.
Yeah, I think certainly this is an extremely important topic. And I think when people think about closing the coverage gap, they immediately go to Medicaid expansion. But I think what that list does show is that there's so many opportunities to improve the coverage gap. And so I'm glad to see that there are lots of great topics on there that we can talk about. Certainly Medicaid expansion is one, but access to healthcare in rural areas and telemedicine and the many other things that's listed are things that I think we do have a lot of common ground on, and we probably can reach some agreements on in terms of the principles. So I appreciate those who filled out the survey and would encourage the others to complete it as well, because there's just so many things that we can do, I think, to improve care across North Carolina.
And this is Senator Robinson, and I do want to chime in. I have not completed it, and I will. My week has been crazy. But I did want to respond that I noticed that emergency workers kind of fell last in terms of priorities. I want to point out that when you talk about emergency workers, these are people who work in nursing homes, rest homes, people who are first in front of folk with COVID, et cetera. A lot of them are low income and minority people. And those are the folk who are working for minimum wage or less and do not have health insurance coverage, and the first who are highest impacted by COVID. So I want to make sure that we move that priority up in terms of if we were prioritizing populations, we need to make sure we keep that in mind. And I will complete my survey. So thank you.
Thank you, Senator. Anyone else have anything to share? Okay. All right. We are going to move to the next session because I know we have a lot to cover. So this next session is going to be really hearing from the business community and really hearing their ideas on what they think is most important to increasing access to coverage. I wanted to encourage all of the business leaders to just share your thoughts. And, we are going to try to make this interactive. So what we'll probably do is let you all share your thoughts. And then as other folks want to provide input, we'll have time at the end to just make sure that we're able to incorporate that. So I think we're going to start with Andy Ellen. Andy, are you on the line with us?
Yes, ma'am. Thank you very much. Can you
Here
hear me
you are,
okay?
yeah.
So
I can hear you.
I'm in downtown Raleigh, and until an hour ago, I was all good, but they're replacing a lot of plywood right now with glass outside my office. So it's great to see. So I appreciate that. So I'm Andy Ellen, President General Counsel, North Carolina Retail Merchants Association. Again, thank you, Governor Cooper and Secretary Cohen, for having me on this council. Just by background, my association represents about 2,500 members that are retailers throughout the state, and they go from this one store operator all the way to stores the size of Walmart or a Home Depot, that type of store, or Lowe's, who's on here as well. But usually what I hear most from is from the smaller retailers, and usually beginning in about October, my phone rings several times a day with retailers saying, I've gotten my quote for my health insurance renewal for next year. Can you help me? And I think part of that is they see an increase in premiums, and they also see changes in their benefits. And I think we have an affiliated workers' compensation company that we've operated for close to 30 years, that we bundle lives together and employee lives together and are able to provide coverage for that. And they ask us to do the same thing. And I think that sometimes runs us into a place, and I know that, and I'll talk about this in a minute, but especially the one store husband and wife that may own like a bookstore or a men's clothing store that you had up on your screen earlier, they also sometimes fall into the individual market, and they're not going to qualify due to income levels for Medicaid. but they're spending, $25,000, $30,000 a year for their health insurance. And that's what really puts intense pressure on them. And it also puts pressure on them as far as what they're able sometimes to offer their employees going forward. I think that's part of an issue that we have in North Carolina, and some have attempted to solve, that to get into the small group market, you have to have at least 2 employees. And so that causes more people into the individual market, which is quite expensive. As we look at COVID, I also worry, we've moved more and more into sort of a gig economy with independent contractors. And I think you're having more and more people that used to work for a larger corporation that are now an independent contractor, and who went from paying a reasonable amount of money potentially for their health benefits, and now they're back into an individual market. And I think we're going to see more of that as we move through COVID. Another item that we've heard repeatedly lately is, the businesses that are struggling to get through to the other side of COVID, and we hope we're on that with the vaccine, of getting there. But their expenses have also gone up. Their sales in a lot of cases for retailers or restaurants or others have gone down. And I think they're trying to make difficult choices of how to continue to pay the rent, pay for their inventory, maintain those benefits that they have previously provided for their employees, but they're just trying to stay alive to get to the other side. And it worries me long term of where we're going to get to when we get to April or May or June, and those businesses continue to make those decisions about where to go with that. Again, the labor costs going up, the sanitation costs, and all those that they need to do to provide that safe shopping experience for their customers and their employees. But they're also trying to struggle with how to maintain expenses and how to maintain cash flow. I think, and you had on your survey some of the issues that were up there. I think we're hearing a lot more too about the mental health issues that have come with COVID, of managing virtual school and managing keeping your business open and managing all the other things we're managing healthcare wise. Some of the things Senator Robinson mentioned as well. Those are weighing on people, and how do we address those mental health concerns that we're in, probably more so than ever. Same way with substance abuse and other items that have come out of COVID at times. We were very interested in, and we worked on the Association Health Plan bill, Senate Bill 86, and I know we're going to have some more on that passed with bipartisan support in both the Senate and the House. That's been tied up in federal litigation. It was argued last November of 19, and we still are awaiting a decision. But it may be a time, I think, to take another look at that and see if there's another way to address that issue and going forward, because I think that's what a lot of the smaller businesses need, retailers, restaurants, any kind of smaller business, is the ability to band together and have the ability like a larger employer. I gave the example as well of, an employer that I recently talked to that was trying to recruit an employee for talent level that was going to promote that person up into their organization. But the cost of their family health coverage was almost double at the small employer than it was at the large employer that was self-insured that they were currently working at. So even with the salary increase, the health costs for their family was going to wipe out that salary increase. And so it makes it difficult on small businesses to recruit the talent that they need to grow those businesses organically throughout the state, both in urban and rural areas. Some of the other issues, and again, I want to listen and learn more than I talk. We have, some of the things about practicing at the top of the license while also maintaining that medical home that I know is so important to the medical providers. That's something we also have interest in. And then how do we prepare a workforce going forward for healthcare? And I think that's one that sometimes gets lost of, especially in rural areas. How do we get those providers into those rural areas? How do we continue that pipeline? And I know the governor's worked very hard on workforce development, but how do we continue that healthcare pipeline of nurses and pharmacists and physical therapists and others throughout the state? So those are some of the things that we're hearing. We have very much an interest in potentially a tax credit, that you mentioned, if that's a way to help ensure that people maintain that insurance so we don't see those numbers rise up after we get through or out the other side of COVID. But thank you very much, and I appreciate the opportunity to speak today.
Thank you, Andy. That was great. Good to hear from you. We're going to go next to Gary Salnido.
Thank you, Hemi. Folks can hear me this meeting? That's good. I fixed my technical difficulties from last time.
Yeah,
that's right. I'm pretty sure Chip muted me. If there was anybody that would have muted me with it. So thank you for the opportunity to be here. Thank you for pulling this together. It's very much appreciated. And we look forward to the discussion going forward. And from where we're sitting, a number of our members, one of them on this call and on this panel, we share with Andy. So Andy very articulately laid out a number of the issues that are very similar to what we're feeling at the chamber. A little bit of background on me, because I didn't have a chance to do that before, and then I'll jump into 2 or 3 things that we think are critically important and prioritized. I'm a pharmacist by education and training, practiced in both hospital and community pharmacy way back when, longer than I'm willing to admit, but have been trained that way and kind of process information and process problems that way. And how we begin to process too. And it's first, do no harm. Second, look at the signs and the symptoms, and then make a diagnosis and a care plan going forward. So whether it's healthcare or any of the issues that we're facing, that's the kind of the screen and the process that we go through. Spent 19 years at GlaxoSmithKline, all in the advocacy, government affairs, understanding the Medicaid piece of the business, the Ryan White piece of our business, and helping people get access to medicines that need them, particularly those that are in positions where they don't have any other alternatives. So appreciate the hard work and the challenges of folks that are trying to get access to care in those areas. And I came to the chamber in 2011 to lead the government affairs and the advocacy efforts, and was privileged and humbled back in August of 19 to be asked to serve as the president and CEO of the organization. We have about 35,000 members, about 1.2 million North Carolinians are employed by those members, have an 80-member local chamber federation of local chambers that we work closely with and we communicate with, ranging from Raleigh, Charlotte, Asheville, down to much smaller chambers that we are continually listening to, who are composed of those small businesses that Andy was referring to. So we have a network where we listen a lot to them, and we also make sure that we communicate with them the broader trends that'll be affecting their business. Our membership has 21 different industry segments across, so we have a great diversity of who we're hearing from, great diversity of size and who we're hearing from on a regular basis. And those folks are all have a couple of things in common, which I'll share with you. And as we get into a couple of specific ideas that we think that can provide a uniquely North Carolina private sector opportunity solution to help with the coverage gap, it was really resonated with me at the end of the last meeting when Gene Woods talked about the top priority that as we come through and recover from the pandemic that we're all facing, regardless of industry segment and whether we're fortunate to be employed or we're going through a really challenging time right now. And that is, how are we going to work with our citizens across the state, across different geographic and socioeconomic circumstances on mental health recovery? And how are the private sector companies doing that? How are self-insured companies doing that? How are insured companies doing it? And how can we learn from each other and educate each other on the importance of mental health support and services going forward for all of our citizens who, particularly the frontline healthcare workers, but all of our citizens who were very quickly thrust into isolation. So I think if we hear the same kind of things that Gene talked about and feel that looking at mental health, deeply looking at mental health across market segments, across people, across populations is really important work that we can do here to begin to develop some common understandings, guidelines, principles that through small, medium, large businesses and through government that we can do collectively together to make sure that we address the most immediate need for folks that are unemployed or folks that are employed that are trying to figure out what the integration back into the workforce looks like, because it's going to be different it's different between industry segments, and it's different between companies within industry segments, and it's different for sizes. And as all of you know, we really never really know personally what all of our citizens and employees and folks are dealing with as a result of the pandemic. People are all dealing with a number of different stresses. So overarching mental health is an issue I hope we spend a good amount of time on and learn from each other about how collectively through the private sector initiatives and the public sector, what we can do for our citizens Underneath those two, I think there's two things that we hear a lot about. And one is Andy articulated really well, the importance of safe, reliable, effective association health plans that can aggregate people together and sit down and talk about developing plans, developing systems to help people get quality, affordable coverage and begin that process of paying for health that we talk about so much. There are some great examples of it out in our state. How do we catch people doing good and tell everybody about it and begin to scale that? There's some good going out there, and let's figure out what that is and let's scale it going forward. So the Association Health Plan has great promise. We can do it uniquely in North Carolina. We can do it safely. We can do it making sure that pre-existing conditions are covered, and we can do it the right way. And I have very confidence in that. We commissioned a feasibility study last year to talk about that piece, and it's going to be part of what we continue to advocate for going forward. And the last piece I would add is the critical importance of telehealth and coverage for telehealth, and working together to find out how we can get telehealth coverage and how we make sure that people, particularly in our non-urban areas, but all across our state, have access to telehealth services appropriately, safely, with predictable costs going forward for all of us. Essentially important. I have a couple of elderly parents that, absent the ability to have telehealth coming in and helping me and my family to navigate some of the challenges there, I'm not sure how the outcomes would have been as good as they are. We're very fortunate and blessed that they're healthy and safe, but those telehealth services really made a difference. So I encourage us to look for ways to incorporate telehealth services across our principles, and to look at association health plans as a way to help small and medium and individuals who are having those real challenges now. So thank you for the opportunity. I appreciate it and look forward to sitting and listening and learning also.
Thank you, Gary. Both you and Andy, I think, put forth a lot of great ideas. I wanted to turn now to Cassandra.
Good morning. Again, my name is Cassandra Brooks, and I operate 2 childcare centers in Wake and Johnston County, Little Believers Academy. And I want to thank you again for the opportunity to share this morning as it relates to the childcare industry. I also want to thank Andy and Gary, who's gone before me. They've shared a lot of great information as it relates to telehealth. And some of these things do fit alongside child care, the business platform, and some do not as far as association. But as an example, I just want to share my industry is essential. We've evolved into a more of an essential needed business since the pandemic. We serve children, mostly of essential workers and more, so that they can return to work. We serve remote learners when school was out, and of course all the public schools shut down. Childcare was right there to provide that service to families so that they could still work. We also are very essential to nurses and doctors, so cashiers can get to work, you name it. So pretty much we are the backbone of every business, so employees can return to work. And without us, many parents are not able to work. Many parents of young children have lots of expenses, including childcare, and we have to try to make this affordable and balanced so that we don't price them out and they can still afford to bring their children to childcare, all while trying to maintain a balance in the business. With this balance, oftentimes we're not paying a living wage to the employees. The employees often work in conditions that they're not able to social distance, which increases their likelihood of getting any type of sickness and just not COVID. 95% of or more of educated early childhood teachers do not have health insurance. Oftentimes, many people look at this sector as a sector that's not educated, but many of the teachers do have bachelor's degrees and some master's degrees as well to being able to teach young children. And I just wanted to share, for example, just this week, I had an employee who contracted pink eye from a student in her class, and she doesn't have health insurance. She's an educated teacher, 4-year degree, but she doesn't have it and she could not afford it. She was trying to determine how she could best get this taken care of so she could return back to work all, during this Christmas time. And oftentimes, they have to decide whether they're going to take medicine from friends and family because they don't have health insurance, they don't have medications, they can't afford it. So those are just some of the real life examples that happen every day. I also wanted to share with you guys, when you when employees go through this and they have to decide between health and paying a bill, or their health and taking care of other bills, their body can't withstand. In the past, I have lost 2 employees since I've been in business due to a preventable condition. 2 employees, they were not old or sickly, if you will. They were in their 40s, and they both died from a preventable condition. If they would have had access to health care, they would have been able to be treated for that preventable condition, and they still would be with us today, and their families. As a small business owner, this really weighs heavy on your business. You need to have healthy workers who are able to work daily, and this is across all segments. I just want to encourage and, reiterate what Andy said about the telehealth. I believe that it's just not going to be just a straight arrow way to getting this taken care of. I think there's a pronged approach. I think, we really need to make sure essential workers are covered first with this healthcare expansion that we're trying to move forward. I think we also need to look at telehealth as being like a staggered approach, and perhaps that's a way to help cut some costs and save some money, and then, tier them up as they need their, of course, yearly physicals and things like that. But I believe that is some of the things that are needed. And I just wanted to, share about the childcare industry. It is, really hit hard like many other businesses right now, but we are essential. We're still, we never closed, we never shut down. We still provided that care each and every day. I've had employees who've contracted COVID-19 during this time, and I just, really pushing for a healthcare that's needed in this industry and for essential workers. Thank you.
Thank you, Cassandra, and thank you for those real life examples. That's very helpful for the discussion. Wanted to turn now to Reg Henderson.
Excuse me, Hemi, can I ask her a question, please? This
Oh,
is Senator
sure.
Rob.
Yeah, go ahead.
And I hate to, I'm not as technological as some of you, so I have to butt in. I can't get my chat up. But I'm on a local child care board, and what I've learned, some of what I know already, but one of the things, in addition to lack of health care, is it can be an entry level for getting people into jobs. And if you can afford to pay a livable wage. But I also learned that the barrier, and I'm saying this to us as policy directors, one of the barriers is that for a lot of these parents, they're Medicaid, but if they make a little over the amount of money, then they lose all of the supportive benefits like childcare, et cetera, which is like $1,000 a week, and they can't pay that. So have you seen that, or can you comment on that? Because it boxes them in. We want people to get into being able to be sustainable, make decent wages to take care of their families, have health care, et cetera. Because folks always complain about folks on welfare. Well, we've got them boxed in with a system. So can you comment on that in terms of how our policies keep those folks from moving ahead?
Yes, Senator Robinson, you really hit the nail on the head as it relates to, I'm working with families who we're trying to push them up, encourage them to go to school, all these things so they can increase their wages and increase their, things for their family. So I have, during my time, I've seen families who have had twins, and they were, the mom just barely received like a $20 raise, and they cut all her childcare off, which she was not then able to even afford it because she had a set of twins. I've seen families who said they didn't want to get married to their significant other because they knew that they would get cut off, and they could not afford childcare, and could not afford all, missing out on some other things. So they didn't want to even get married. So it boxes them in, and you're exactly right on how far they're able to grow and develop. I was talking in another thing, and this might not even be the segment, but when I was in college, they had many opportunities for me to continue to go on and be great, if you will. We had access to healthcare. We had access to childcare vouchers. We had access to just you name it. We had Section 8, just different things so that a person would not get boxed in and they could go up and, and keep pushing through. But right now I do see that there is a total box, and people know that they have to stay within this, or else that's it. All of their benefits are gone, and then they, that's it. And so I definitely agree with you, Senator Robinson. I had a daughter in college at North Carolina A&T in Greensboro, but that, I did have the support of my family, but I also have the support of different programs within the state of North Carolina. I had access to if you will, food stamps and Section 8 and different things. And so that allowed me to catapult me up so that I can continue to grow and finish my bachelor's degree in management, and went on, and just continue to thrive after that, and, working towards my master's degree. So yes, we do need programs that are going to just not box people in, but allow them to grow, allow them to be able to become effective citizens in North Carolina and help us. So you hit the nail on the head. Thank you.
Great, thank you. And Representative Cunningham wanted to make a comment.
No, thank you. Thank you. I wanted to ask Ms. Brooks a question about,
okay.
Thank you. So it used to be when an individual became unemployed and they were receiving the child care resource voucher, that they had a certain amount of time to regain employment before they would lose their voucher. Tell me about that now.
Yes, in the past, they have given them anywhere from 30 to 60 days to try to gain, look for another job and sustain employment before just kicking them off. Right now, I've seen different things, I guess, because of the COVID crisis right now. I've seen different things where they just cut them off, and then the family, they're told, I just had a family, I think 2 weeks ago, they told them they have to start over. And when you start over, starting over is just not go and putting your name back on the list to start over in a week or in a month when you get a job. Starting over is a year, if not longer, to be able to get childcare. And so that again goes back to boxing a person in. When they don't have that support, they're not going to be able to be effective citizens. And so you are right, when we don't have that necessarily defined between all the counties where they can be able to get that, get the voucher and try to look for work at the same time. And of course, like, they said, the industries have changed right now because of COVID, and you can't necessarily get a job quickly as you were before, prior to the pandemic. So yes, that is another issue that keeps people boxed in, such as Senator Robinson said. We have to at this point try to produce some quality leaders. And so we do have to push down and pull up so that we can get to the next level as a state.
Thank you. Okay, I wanted to turn now to Reg Henderson, who's the Vice President of Government Relations at Lowe's. Reg, are you with us?
Yes, I'm with us.
There you are. Yes.
Yes. Good morning, everyone. Again, thanks for this opportunity just to be a part of this conversation. And as she stated, I'm Vice President of Government Affairs at Lowe's, but just backing up a little bit, while this issue would be really close and near and dear to me, by training, I'm an employment and employee benefits attorney practicing for corporations, including Lowe's. And then I've held senior roles in human resources at large corporations. And I see firsthand the importance of keeping our associates healthy, because it drives into, if they're healthier, they're more productive for themselves and for their families. And it makes them more productive and engaged associates. It reduces the burden on the health systems, and it keeps costs down so that coverage is more accessible for all. So the question that we ask is, how do we keep our 300,000 plus associates healthy every day, of which 30,000 of them are in the state of North Carolina, with our headquarter office here in Mooresville, with about 6,000 employees there. And so to do that, one of the things that we've really focused on in the last several years is preventive care and encouraging it to all of our enrolled population, and making sure that we have enough healthcare plan options that they're accessible to our workforce and affordable to them. And just to share with you some of the proactive work we've done in healthcare is every year we have targeted campaigns throughout the year, not just one time a year, to remind associates based upon their age and gender when various preventive care recommendations are due. And our data is in line with national data. It shows that when associates get preventative care, they find issues earlier, which results in better treatment outcomes and potentially lower overall costs. And our employees with established preventive care providers seek preventive visits at a substantially higher rate than associates who don't have them. And these preventive visits are a critical opportunity for the early identification of chronic conditions, as well as keeping members with existing conditions from progressing to a worse stage of a disease. And our members have performed below benchmarks for preventive screenings, which is an area of opportunity for us, and we've recognized that, and we're addressing that in 2021. And it's only been exacerbated in 2020 due to COVID-19. And so in 2021, we plan to have robust communication programs to re-engage our workforce there. And some of the types of prevention that we've done is healthcare screenings. It's covered 100% under our health plans. Diabetes prevention programs, we have services provided through our vendor partner, and we'll even have enhanced communications around that in 2021. And obesity is one of the most significant drivers of preventable chronic illness and illnesses. And so we have services provided through our vendor partners, and we'll even have enhanced that in 2021. And one area that we've seen one of the most preventable chronic illnesses is hypertension. And so with that, we're going to have programs that are targeted around prevention of hypertension through education and launching those programs in 2021. In addition to some of the preventative care stuff that we do is just making sure that we manage diseases and other conditions and make sure, and we do that early, like for example, have an on-site health clinic. We found that to be valuable in places where our associates are able to go and get the care that they need right there and without any cost. We found, in addition to physical health, mental health, virtual offerings, that's important. So regardless of whether our employees are enrolled in our healthcare plans or not, all of them have access to 5 counseling sessions per issue, per family member. These sessions can be conducted in person, telephonically, or virtually with a counselor. And in addition, we offer a virtual self-paced program to associates in lieu of the one-on-one type counseling, because that's an issue that we've seen really important, and we found successes with that. Telemedicine, that's been mentioned here today. That's something we've offered for several years, and we even expanded the coverage temporarily from March through August to folks who weren't enrolled in any plan to make sure to assist during the first wave of COVID-19. And one thing that I failed to mention when I was going through talking about on-site health clinics, that's something similar to Representative Adcock, what she did, oversaw at SAS. So just wanted to make that call out. And yeah, I talked about diabetes prevention, but in addition to the prevention piece, when people do have diabetes, we have management programs for that. So the two things that we've really found to be valuable, and if we think about healthcare solutions, is if there are preventive programs that are offered for folks, because that's something that if we've seen in line with other national data, that really reduces the burden on the healthcare system. And when we think about it from a corporate perspective, if we're going to be a responsible corporate partner, is how we not only just help our associates, the 30,000 that sit here, but how can we help all of North Carolina? And one of those ways is reducing that burden on the health system, as well as providing options to our employees at the lowest cost available, so that they can lean into our plans as opposed to have to get publicly assisted plans and putting that burden on the state. So thank you, and just thank you for being a part of this conversation.
Thank you so much. And I think highlighting the importance of preventive care for your employees is a really good point. Now, I do want to make sure we get to Vivian, and I know we're running a little bit short on time in this session. After Vivian, I do want to circle back. There have been a couple of questions in the chat about, specifically for you, Reg, about stabilization or reduction of your company's healthcare costs as a result of your efforts. But I want to make sure we get to Vivian first and then circle back to those questions. So Vivian Howard is a chef, restaurateur, and author. So Vivian, are you with us?
I am.
Yeah.
I don't know, Emma, I can say. Yes, my name is Vivian Howard, and I am a small business owner, restaurateur in Eastern North Carolina. I also consider myself an advocate for people who live in rural America. And, for me, healthcare coverage is a huge issue that I think has to be, approached from multiple places. But I was charged with kind of talking about how this Medicaid expansion relates to the restaurant business or small businesses in general. And so I'll just kind of break out what my business looked like and what it looks like now, and how I feel as if Medicaid expansion might affect what we do. So prior to COVID, we had 3 restaurants, 2 in Kinston and 1 in Wilmington. Chef and the Farmer, which many of you may be familiar with, was our first restaurant, and it has been open for 14 years. March 10th, whatever the day was, when we closed the restaurants for COVID, we had about 160 employees. The average age of our employees across the restaurants is about 30 years old. The average income of one of our employees was about $35K a year. So Medicaid expansion, as it relates to our business as it was prior to COVID, would actually affect about 15% of our employees. For the last 5 years, we have carried 70% of healthcare costs for our employees. And the only incentive really to do that was a moral one. It has always been a strain to provide that. And over the last 5 years, we've paid roughly $1 million in healthcare coverage for our employees. Restaurants, I mentioned, the average age of our employees is 30 years old. So many people who work in restaurants are young. So many of them do not have, come to us with health care. They don't really, in many cases, have a lot of healthcare needs, but when they do, they're big. And so we feel an obligation to provide some sort of healthcare for our staff. Now, that being said, I started in March with 160 employees. We have roughly a third of that now. And the way that the restaurant industry looks at this moment, particularly independently owned restaurants, I don't know that we'll be able to do the things that we once did when we're on the other side of this. And so for me, healthcare coverage as it relates to small businesses is a very big topic. I feel like for us, Medicaid expansion would absolutely be a step in the right direction toward making this challenge one that is surmountable. As someone who lives in rural Eastern North Carolina, I also see Medicaid expansion as something we really need. You know, there's been a lot of talk about telehealth on this call and the previous one. But, you know, I couldn't have a telehealth appointment at my home if I wanted to, because I don't have high-speed broadband internet. So the other thing that is really clear when you live in a rural place is how important our local hospital is, you know, both to attract people to live in the area and just, you know, basic access to care. And if I listen closely on our last call, it seems as if Medicaid expansion would be a step in the right direction to keeping our local hospital up and running and available for our community. So I would love to see more in-depth conversation around how to make healthcare available for all North Carolinians. I do think that Medicaid expansion is a step in the right direction. And I really liked hearing the idea around tax credits for small businesses that provide healthcare coverage for their staff, because we will need an incentive aside from just a moral one moving forward.
Great, thank you, Vivian. I want to circle back. That was great to hear about sort of your rural perspective. I wanted to circle back on a couple of questions that came up. So wanted to share those. So one is, and I think this would probably be for anyone who just spoke on the panel, but Reg, this may be directed to you. For all the efforts that Lowe's has done, have you seen a stabilization or reduction in healthcare costs? And there was a follow-up that was just chatted to me. I think there's a concern that, you know, having a lot of uninsured, does that raise costs for businesses? And, you know, the measures that you were talking about for your employees that have insurance, do you feel like that's a stabilizing factor?
Yes. Okay. Yes. The answer is yes and yes. Yes, we have seen stabilization of our overall company health costs as a result of these measures, because we're pretty aggressive about it. You know, I talked about we do campaigns, but to just bring that just to life just a little bit, like every morning, if you're in a corporate setting, which we have a lot of those, the 6,000 in North Carolina, when you log on every morning, your landing page that's just for our employees, we talk about it. So that's front of mind. It's more than once. Our CEO does a podcast to our all of our population, hourly and salary population, every single week. And those messages are interwoven into that podcast where he's talking to them. If you're in a store environment, our store managers every day, every morning, they do a pull-up meeting every single morning. So those things are brought up there as reminders. So you get reminded of it. And yes, as a result of all those efforts, it has stabilized our overall cost. Was there another question that I missed about it? Or did I?
Yeah, and this could be for perhaps anyone on the panel. It doesn't have to just be you, Reg, not to put you on the hot, but I think there was a message question about is the number of uninsured in North Carolina, does that raise costs for employers more broadly because there are so many folks who are uninsured? I think that's just a question. I don't know if there's anyone on the panel who wants to respond to that. Anyone want to comment on that? It's okay if the answer is no. Okay. Vivian, there's a question for you from Senator Robinson. She had a question about, do you see a significantly higher percentage of your 30+ employees needing mental health rather than or in addition to physical health care?
I was trying to read the chat, so I didn't hear the last question. So if it was for me, then just ask it again. But I was reading this question. You know, I think the mental health piece is harder to see than, you know, the physical health piece. But I think that so I don't think I can answer that, you know, accurately. But I agree with everything that I've heard related to the need for more mental health resources, because I think it's something that we have turned a blind eye to for quite some time. And if I had to guess, I would say yes, that a higher percentage of my 30-year-old plus employees probably, if mental health care were available and easy to access, they would probably seek it out.
Thank you. And Representative Adcock had some questions around association health plans, and we are going to be talking about that in the next session. So perhaps just a couple. Gary mentioned there are several good AHPs in North Carolina, maybe following up on that, but then talking about sort of the litigation, et cetera. We are going to talk about that in the next session. So I might hold that question then. But Gary, do you want to make any comments about several good AHPs in North Carolina and just any follow-up on that?
I mean, I'm not aware of any AHPs in North Carolina. There's plans for specific groups under the MEWA laws, but association health plans, because of the litigation and because we don't have a specific area in the statute that defines them and addresses them, I'm not aware of association health plans in the context that Andy and I are speaking to about them. Rather, they exist through the MEWA structure right now.
So if I could just say, add on to Gary one piece, and this may be in the next one, you have some self-insured programs, as Gary mentioned, from the Bankers Association and the Bar Association. And I think the Medical Society also has a form of it, but you don't have any fully insured programs that are based around trade groups or associations. That's what I think the legislation was attempting to do. It's very difficult and costly because the payment tail is so short in the health sector to do a self-insured type plan at this point in time. 25 years ago, maybe. Now in today's world, it's really difficult, which is why we were trying to develop one that was fully insured, that process going forward in North Carolina. But I look forward to hearing more about that in the future presentations. But thank you.
Yes. Okay, great. And I think we might pivot to the next presentation just in the interest of time.
Before we go, can I I don't mean to jump in, but I was hoping maybe Tunde from Blue Cross maybe could jump in on the question you asked related to the cost shift that happens with the uninsured, and how when we have higher number of uninsured here in North Carolina, what that does for the cost of healthcare for everyone who does pay to someone like Blue Cross. So maybe Tunde, I know you look at that data, if you don't mind jumping in.
Yeah, that's great. Thanks, Mandy. Yeah, that's absolutely correct. I mean, typically when you have high numbers of uninsured, it's almost like a perfect storm, because then they don't have access to care. They have delays in care. And then when they access the system, typically the resources that are consumed are extremely costly. So at the end of the day, what that tends to result in is, the system has to bear the cost, somehow. And that typically results in increases in premiums, for those that are covered, to provide, to offset the costs for those that are uninsured and accessing the system. And you typically will see, I'm sure if you ask Gene, he would probably attest to this, that, when you have individuals that are accessing the health system, what typically happens if they're uninsured, they don't have coverage, and we have to provide services to them, even on the provider side of the spectrum, then that raises the overall costs that are incurred across the healthcare system. So that increases medical costs across the system, and medical cost is a big piece of what you and I, all of us, pay with respect to our premiums. So it almost becomes like a self-fulfilling prophecy at the end of the day.
Thank you. And thank you for responding to my earlier question. Don Flo, I think you wanted to comment. Go ahead.
I wanted to make 3 comments, and one to follow that up. I think some folks know I've been a public advocate of the expansion, and the reason why is I sit in 2 seats. I own a company that has 1,800 employees. Also been chair of a medical center. So I could see the consequences of charitable care passed back to me in my business. In effect, it's a transfer taking place because we got to cover the folks. That's just a reality. It's an economic reality. But we can't create money. So consequently, we got to pass those costs to the system, which drives up the cost to businesses in the long term. And it's just an unhealthy system long term in the present state we're in. But my comments, that's my first comment. The second comment is that I wanted to follow up the comment made from Gary from Lowe's, which is we've had the good fortune to partner with Wake Forest Baptist, now Wake Forest Baptist Atrium, to come and attack this. And so it shows that there are some models for larger companies to be able to go do this. Very similar to their experience. Actually, our healthcare costs have cut in more than half relative to the national growth. But this, in a sense, is making the big bigger and stronger. And that's not what we need to do in this state if we're really going to flourish as an entire state. And so giving smaller businesses access, this is really important aspect for where we're going. That's what Gary's conversation about associated plans and other things. We need to be the leader in the country of how we allow this to take place along the way. And then the last thing I'd say is we get to see this, the personal impact upon people who don't have coverage. Candidly, it wrecks their credit. And it puts them in a spiral that puts them into a subprime world. And so if they were marginally making it, now it puts them down below it because it takes them out of the regular banking system. And almost every single time, it's their inability to make their payments on something associated with healthcare that throws them out. And so as a state, if we're going to flourish as an entire state, we've got to address these issues. And they're the key of economic mobility in both our rural communities and our urban communities. And so for me, this is why it's a matter that takes on from every point of view. Large companies, medium companies, and small companies have got to be addressing this. Thank you.
Thank you. That's great comments. I know there's a lot of comments in the chat about association health plans and the impact of association health plans, et cetera. So I think we should pivot perhaps to the next session and try to address those questions in that context. So I'm going to go ahead and turn first to Dave Richards. So Dave is going to talk briefly about increasing access to coverage for pregnant and postpartum women and parents with foster children, which Cassandra talked about. And then we're going to pivot to the association health plan and reinsurance conversation. So Dave, I might turn this to you now.
Amy, thank you very much. And I promise I'll be quick. There are, so we can just flip through the first slide. This is what we're going to talk about. Flip through that one. That's pretty good. We've gotten through 2 real fast. Just a little bit of background about the maternal and infant mortality and crisis in the country. Excuse me. You see that we are the only industrialized nation to experience increase in maternal mortality during that period of time. It's particularly acute with Black mothers who more likely to die in childbirth than white mothers. And maternal-related child deaths and illness can occur up to a year following birth, and we'll talk about that in a minute. North Carolina doesn't do great. We're ranked 30th in the country in terms of maternal mortality rates. 12% of women in North Carolina experience postpartum depression. I think that's one that's most we worry most about. It's 39th nation in infant mortality, and getting this D+ is not something we ever want to see for North Carolina. So we can flip to the next one. This is really important as you think about maternal health risk persist after childbirth. Is that I think what I thought before I saw this slide is that would happen right after childbirth, but the period of time in which those times postpartum happen much more significant than certainly I would have thought, and I'm assuming that many people don't see that either. If we could change to the next slide. Again, infant mortality in the United States, what strikes me is that not only are we doing worse than other states, but we're doing worse than our neighbors to the north and south. And that is something, again, I think we should be striving to be much better than that. And I know many of you have talked to me about wanting to make sure that we improve that area. So if we can go to the next slide. Here's a little bit about, we've talked about, so can Medicaid do something about pregnancy coverage and really help that effort? So just so you know is that we pay in North Carolina for about 55% of all births in the state. We cover pregnant women up to 196% of the federal poverty level, which is a little bit over $2,000 a month. That's the coverage that currently exists. Women are eligible for North Carolina Medicaid for prenatal care and up to 60 days after birth for these services that we list here. But the coverage ends at 60 days after birth for moms with income between 42 and 196% of the federal poverty level. So if you're on Medicaid because of your income level, it stays. But if you're not, you lose that coverage right after, which goes back to that previous slide when you think about what happens for moms and that the maternal deaths actually occur much longer than we would have thought. So we can slip to the next slide. In expanding postpartum coverage, which I know I've talked to several members of the legislature about, is that the federal Medicaid matching money is only available for 60 days after birth under the regular Medicaid program. There are 5 states that have passed legislation to extend postpartum coverage. I know 2 of them are using state-only funds to do that work. Others may have other arrangements. And then 3 states have applied for an 1115 waiver to extend that. And I won't go into detail. 1115 waiver allows you to raise some rules and regulations. None of these states have had these waivers approved, though. So we're not certain that would be something that would be optional that would be available for North Carolina. So if we go to the next slide. And the other comment I'll make on that, again, the other option, obviously, is that if you would to expand coverage in Medicaid, then you would cover many of these women through that process. Parents of foster children, Medicaid eligibility ends for parents if their children are moved to a foster care. About 40% of the children entering foster care are due to parent substance abuse. When the parents lose eligibility, they lose access to those treatments that they could have had, often lose access to that treatment. I think you'll hear Margaret talk a little bit about those substance use issues as we come on. And there are about 6,000 children who enter foster care annually in North Carolina, and they're eligible at the current parent eligibility levels of 41% of the federal poverty level. If we go to the next slide. So I'm going to just say a couple of quick words about those. Those are, we can give you more detail. I know there'll be more questions, but I know we're running short of time. But I know those were questions about expanding coverage to those areas with very targeted programs inside of Medicaid that we want to make sure to let you know how that would happen. And again, we can do more detail. We also have had a lot of questions about our home and community-based service waivers. High level waiver in Medicaid world is one of a few things that actually does what it says. It waives rules, so you're allowed to do more flexible things for people to allow folks that might have had to be in an institutional level of care to receive those services in their community. We have 4 of those in North Carolina. Our innovations waiver, which is for people with IDD. We currently have an enrollment cap of 13,138 people. We have a traumatic brain injury waiver, which is just slowly getting started with 107 people on that waiver. And then we have 2 other waivers. The innovations in TBI fall under our LME-MCO system, and so they're managed there. The 2 others are our community alternatives program for children and adults. For children, it's for those kids that are medically fragile, up to 20 years old. And for disabled adults, it's for those that are higher than that. Often it is for people who are older. And we have, for those programs, the Cap C enrollment cap is 4,000 people, and for the Cap DA is 11,000, a little bit over 11,000. And have one last slide that we'll get to, and this is really about waiting lists. They're a function of the enrollment caps that we have in a program. So the way our program works is that the General Assembly approves those caps in the waivers and funds when we wind up having additional waiver slots. Innovations waiver, the IDD one, which is probably where many of our members of the General Assembly hear the most, about 14,000 people on wait list there. Our TBI waiver, that's not a wait list, but it's really small. So we know there are a lot of people in the state that once it rolls out further will want that. For our community alternative program for children, there isn't a wait list. We have enough slots right now to cover those. You might imagine because children roll off of that, it winds up having more quick changes there. And for our Cap DA for older adults, we have about 1,700, about 1,800 people there. 2 things I want to mention is that On the innovations waiver, several folks have suggested is that can we do a tiered waiver so that maybe the cost of that comprehensive waiver, which is about $65,000 a year per person, we could do something for people that have less needs. Yes, we can, and we actually had one previously in the state. And again, I think we have had that conversation previously with the General Assembly, and certainly it's something that we can move forward. You could do it in the other waivers, but because the other waivers, especially the C and DA waiver, their average cost is around $30,000. So probably tiering that doesn't do as much good and may be more difficult to implement, but you certainly could do that for the innovations waiver. So Hammy, that was a speed reading approach to those slides. I hope it was helpful. And certainly if there's any question, happy to do it now or at a later time, because I know we've got a lot to get to.
Yeah, I think we should just take one or two questions just because we're going to be moving on to association health plan. So if anyone has questions about sort of pregnant women, postpartum women, children of foster parents, or the home and community-based waivers, please raise them now. Okay. I don't see anybody. Just start talking if I don't see you, but I don't see anybody. Okay.
Great.
All right. Well, you know where to find Dave. So if you have any follow-up questions, he's available. Okay. Thank you, Dave. Now we're going to move on. I know there's been a lot more in the chat about the association health plan. So let's get to that conversation. I wanted to introduce Jordan Roberts. He's a government affairs associate with the John Locke Foundation, and just turn to him now.
Thank you. And thank you all so much for the opportunity to come and present this morning. I'd like to thank the governor, Secretary Cohen, and everyone on the panel for your attention and time to this very important issue of expanding health coverage in North Carolina. I think everyone on the panel can agree and find common ground that we want as healthy and prosperous in North Carolina as we can. So I look forward to presenting and continuing the conversation. So we can go to the next slide. So I wanted to start off with, we can move on to the next one, I'm sorry. I wanted to start off with what is the problem we want to solve. And, to me, it's that health insurance can be unaffordable for those who don't get it from work or from a public program. And a second part of that problem is that those who have health insurance may struggle to pay the premiums and out-of-pocket costs. So at the root level, it's that the problem is that the products we have on the market right now can be unaffordable to a lot of North Carolinians. And so what causes this problem? And this may seem intuitive, but the cost of healthcare drives the cost of insurance. And what I mean by that is the services, the price of services, that is what gets priced into our premiums. And you can look at the research that the United States pays more than any other country for the procedures of healthcare. And so while the panel and my presentation today is going to focus on healthcare coverage options, part of this discussion needs to focus on reforms that loosen healthcare regulations and bring down the cost of care. So that's part of the discussion, and it needs to be, included in all of this. So we can go to the next slide. And the next one. So where I see the opportunities for reform are mostly in the individual market. And for those who don't get health insurance from work or the government, the individual market is really the only place to go. And as you can see on the right side, there's been a steady decline in marketplace participation over the last several years until a small uptick in 2020. So, we've lost over 100,000 people in that market. And another point I want to bring up here when we talk about the total uninsured number and, how we can get more people health insurance, 338,200 uninsured North Carolinians were eligible for a free subsidized Affordable Care Act plan in 2020. So, we have well over 1 million individuals that are uninsured in North Carolina, but for whatever reason, these folks haven't signed up. So if we were to, get these folks signed up, that total uninsured number would look very different. And then another point I want to bring up too in context of this chart is that participation has declined despite the enforcement of the individual mandate up until 2019. So the folks who are dropping coverage, they saw less value in the insurance than the tax penalty. And so I think that speaks to the price and quality problems we have, because this is mainly due to the rising premiums and deductibles that folks in the individual market face. And then one last point is that, the vast majority of North Carolina counties only have one insurer offering coverage on the exchange. And so again, that can contribute to the price and affordability problems. We can move to the next slide. So what are the solutions? The first solution that I want to talk about is state empowerment and relief waivers. And sometimes these are called Section 1332 waivers or state innovation waivers, but we're all talking about the same thing here. But essentially under Section 1332 of the Affordable Care Act, states can apply to the federal government to waive regulations imposed on the individual market. And what this does is it gives states the opportunity to exert a lot more control over the health insurance products that are offered to its residents. And, I think this is a really important thing for states to have control over their marketplace because it's a very unique population. And so most states that have got a Section 1332 waiver so far have set up reinsurance programs. But I want to emphasize that this is not the only type of reform that's allowed by these waivers. The waivers have to meet these 4 guardrails. Coverage needs to be as comprehensive as it was before the waiver was accepted. Coverage needs to be as affordable as it was before the waiver was accepted. And a comparable number of people need to be covered compared to before the waiver was accepted. And then fourth, the waiver cannot increase the federal deficit. So, while, like I said, we'll talk about reinsurance programs and that a lot of states have done that. But as long as you comply by those 4 guardrails, the state has a lot of creative opportunity here to restructure these subsidies, look at account-based reforms to buy health insurance. So we have a lot of options. And I think that's something that, with the minds on this council, we can really look to and have a lot of autonomy through this state empowerment waiver. So we can go to the next slide. So there's a lot of information on this page, but I just wanted to quickly run through how reinsurance works and the status of it in other states. So essentially, reinsurance works as a stop-loss insurance for insurers on the market. So essentially how it works is there's a price point by where any claims that come in above that price point are reimbursed to the insurer some or all of the amount above that price point. So for example, if there's a price point of $50,000 and an insurer would receive a claim for $100,000, every dollar above that $50,000 mark would be reimbursed to the insurer partially or fully, depending on how the program's set up. And the way that this reduces premiums is that the insurers on the market, when they have that prior knowledge that high cost claims, which are a large driver of health insurance costs, are going to be reimbursed, they're able to price that into their rate setting and reduce premiums across the board. And so you can see states have had, or red and blue states have had a lot of, have had 1332 waivers granted, and a lot of these states have had, you can see in that second column there, pretty sizable reductions in premiums. And so another benefit of 1332 waivers is that whatever states can reduce the cost of facilitating that exchange to the federal government, they get that money in what's called federal pass-through funding. And so a lot of states, as you can see from the fourth column over there, they use that federal pass-through money to fund a portion of their reinsurance program. So this is one of the ways that we can, lower costs across the board, set up, some more risk pooling. We can hopefully get more insurers into the exchange that will, increase competition and give more choices to North Carolinians. And we can also bring more covered lives into the risk pool, which can stabilize risk pools and also reduce premiums. We can go to the next slide. I won't get into a lot of this, but Georgia, our neighbor to the south, just had a state innovation waiver accepted. They set up a reinsurance program, and they set up an onboarding model that they call the Georgia Access model that uses private entities. And there's a very high emphasis on local entities working with their communities to sign folks up for health insurance. So I think this is an interesting innovation waiver, and it gives an example of what we can do in North Carolina. So I encourage everyone to go check Georgia's state innovation waiver out too. We can go to the next slide. So yeah, there's been a lot of talk about association health plans, and so I'll run through it real quick. But essentially, association health plans are a type of large group health plan offered by business and trade associations to its member employers. These plans allow the small businesses, self-employed owners to band together to purchase health insurance as a large group. And so why does it matter to purchase a large group? Well, the ACA segmented the market. So there's a different set of regulations for small and individual group plans as compared to large group plans. And so when, as Andy was talking about, with the retail merchant members, if these mom and pop shops and individual retailers can get together and buy health insurance as a large group plan, they can get plans at a much more affordable rate. And this helps everyone, that may be a part of that member association. They're subject to all the same rules that current large group health plans are. So any large group health plans are operating under the same rules. And I think one of the good examples of one of the first AHPs set up was the Land of Lakes Co-op up in Minnesota and Nebraska. They were able to set up member plans that had robust benefits and cost 20 to 30% less than comparable ACA plans. So we've seen this work. There's none in North Carolina yet, but I think when we think about association health plans, we think about how can we help sole proprietors, small businesses, the folks that were really just priced out of the market through no fault of their own once the Affordable Care Act came into place. How can we level the playing field and give them an opportunity to buy health insurance, as a large group? So that's my last slide, but I just want to re-emphasize again that the coverage portion of this discussion is part of it, but we also need to look at the supply problems and think about how we can increase the supply and some of these regulations that artificially increase the price of healthcare. Both of those are going to go into making healthcare more affordable and creating a more healthy North Carolina. So thank you again for the opportunity to come and present, and I'll pass it back now.
Great, thank you, Jordan. And I know there's been some active questions about AHP specifically in the chat. I might just hold those for a moment, only because we have our next presenter, Sabrina Corlett, who's a research professor at the Center on Health Insurance Reforms at Georgetown University McCourt School of Public Policy. And she's been studying both reinsurance across the states and impact on cost and coverage. And she also is an attorney and so has some thoughts around association health plans. So I thought it might be helpful to have her present quickly, and then we can go back to the questions and make sure that we get everybody's questions answered. Okay, I might turn it to you, Sabrina.
Thank you, Hemi, and thank you to Governor Cooper and Secretary Cohen for inviting me to join you all today for this second meeting of the Council for Healthcare Coverage. If you could turn to the next slide. I won't spend a lot of time on this slide, but it provides a little bit of background on our center. We study health insurance issues, and we also serve as technical assistance providers to the Robert Wood Johnson Foundation's State Health and Value Strategies Project, which supports state officials in their in the design and implementation of health reform strategies. And this slide also just has some information about how to access our research and learn more about what we do. Next slide, please. So I was asked to talk about two policies, health reform policies today. And before I start, I'd like to sort of just frame what I'm going to talk about by talking about, there's sort of essentially, and this is a little bit of an oversimplification, but there's kind of two competing visions for insurance regulation. And one vision was embodied with the Affordable Care Act that sort of said, we're going to pool together healthy and sick people into one risk pool. And yes, healthy people are going to have to subsidize the costs of sicker people. But it was sort of this social insurance vision where we subsidize sicker people because we know that we all get older and sicker someday. The other vision, which was in existence in most states in the individual market prior to the ACA, was that health insurance was sort of treated almost like auto insurance or other types of insurances, where the price you paid sort of reflected the risk that you posed. So sicker people tended to pay more than healthier people. Of course, the ACA completely reformed that and set a different standard in most states starting in 2014. So the first policy I'm going to talk about is reinsurance, which Jordan did a great job summarizing in his presentation. But reinsurance is sort of adheres to the ACA vision of pooling together these healthy and sicker individuals in the same pool, but provides some government subsidies to sort of smooth out the risks of letting those sicker people in the pool. The ACA did have a federal reinsurance program. It expired in 2016. And when it did, actually, that was when we saw premiums go up in most states in 2017, partially as a result of the expiration of that reinsurance program. So we saw, as a result, states implementing their own reinsurance programs, 14 states by 2021, with Georgia becoming the 15th state in 2022. So if we'll turn to the next slide, please. I won't spend a lot of time on this page because Jordan had his map as well. But this slide does provide some data on the dates in which these states implemented their programs, Alaska, Minnesota, and Oregon being the first, and Georgia being the most recent, again in 2022. Next slide, please. What has been the impact of these programs? I think Jordan did a great job showing us the premium impact. I think it's important, first of all, to note, however, that this is the impact on unsubsidized individual market premiums. There's actually no real benefit for those who are between 100 and 400% of the federal poverty line because of the way the Affordable Care Act premium subsidies work. And actually, some of those subsidized individuals could face higher net premiums if they don't actively switch to a lower cost plan after the reinsurance program is implemented. And it's complicated, but basically because the premium tax credits are pegged to the second lowest cost silver plan in the market, when that premium goes down, so too does the amount of PTC that an individual receives, unless they have to get to switch to a lower cost plan in order to get the same bang for the buck. So next slide, please. Yes, this one. So we also important to know, what does reinsurance do to impact enrollment? And what we've seen is, and first of all, just a caveat on this chart here, because these are raw enrollment numbers. The declines in enrollment here are not necessarily related to reinsurance. There were a lot of factors at play. So on this slide, you'll see, for example, Maine, I saw a big decline in enrollment, 18.2% decline, but they also implemented Medicaid expansion at around the same time. So a lot of those folks between 100 and 138% of poverty shifted out of the individual market and into the exchange. And New Jersey and Wisconsin also saw declines, but those also coincided with very large cuts in the outreach and marketing budget for the federal marketplace. So there could have just been less consumer awareness. So the important point here is not to say that reinsurance leads to enrollment declines. That is not the case at all. But I do think it is fairly safe to say that it is not a magic bullet for increasing enrollment, if that is the goal. And in fact, could cause modest declines in subsidized enrollment if people do get a premium jump as a result, if they don't actively switch to a lower cost plan. Next slide, please. So to summarize, the reinsurance program, as Jordan said, is absolutely a proven program to lower unsubsidized individual market premiums. And the state can leverage federal pass-through dollars. In fact, all states that have implemented a 1332 reinsurance program through a 1332 waiver have been able to generate federal dollars to support that. On the other hand, the state must figure out a way to finance a portion of the reinsurance fund using state dollars. And the evidence suggests there is little impact on enrollment, and it actually could increase net premiums for some folks under that 400% FPL level. Next slide, please. So shifting to the second policy, which is association health plans, I think these arrangements reflect the alternative vision for insurance regulation that I spoke about earlier, essentially segmenting the market between the healthier and the sicker. Of course, AHPs have been around for a long time, and they're often offered to meet the health insurance needs of trade and business association members. In the past, they've also been offered by insurance companies to individuals through association products. They are jointly regulated by the states and by the federal government. They were fairly popular before the ACA. Many states exempted them from state insurance rules. But partly because of that, they have unfortunately a long and fairly sordid history of taking premium payments from policyholders and declaring insolvency or even committing fraud, leaving policyholders and providers holding the bag. And that's partially because of the dual way in which they're regulated. Some of the operators of these AHPs became fairly adept at taking advantages of the gaps in oversight and enforcement. So in 2011, federal rules were published saying that association health plans selling to individuals were required to follow the same rules as ACA plans selling to individuals, and associations selling to small employers were required to follow the same rules as insurers selling to small employers. And it's that policy, which was enacted in 2011, is often called the look-through rule. Essentially, the government's going to look through the structure of the association to see what is the market that that these products are being sold in, and then those are the rules that the association has to follow. In 2018, a federal regulation was published that loosened the standards that would allow association health plans to be considered a single large employer plan. And this essentially enables them to get out from under the ACA rating rules, the single risk pool that applies to the individual and small group market, as well as benefit standards. This policy, as Jordan mentioned, however, was challenged in federal court, and the AHPs that would meet these standards have essentially been enjoined from trying to seek new enrollment pending the appeal. I would also note that while we don't know exactly what the Biden administration's policy will be with respect to AHPs, this litigation that's currently pending before the Court of Appeals could be mooted if the Biden administration rescinds or revises those regulations. That said, and I think Jordan alluded to this in his comments, the states essentially retain most of the regulatory authority over AHPs, and so have a lot of flexibility in how they regulate them. And so after the 2018 regulation, we saw a number of states enacting policies of AHPs, particularly those that are self-funded because they have been a particular source of insolvency, setting additional standards, for example, requiring them to exist for a purpose other than simply selling insurance, and also making sure that they're meeting the same licensing standards that commercial insurers have to meet. Other states have enacted laws and rules to maintain a level playing field and limit adverse selection, for example, by implementing the 2011 look-through rules at the state level, or by prohibiting enrollment among the self-employed to try to make sure that the individual market risk pool stays balanced between the healthy and the sick. And then a number of states, such as North Carolina, have tried to encourage the expanded availability of AHPs by conforming to the 2018 federal rules, although that, of course, is on hold. So next slide, please. I will summarize by just saying that AHPs can offer lower premiums for employers and individuals with a healthier risk profile. However, the risk is that it could result in higher premiums for individuals and small employers that remain in the ACA regulated small and individual markets. And then, of course, there
I think Sabrina's frozen.
Yeah.
There is this history of infusion. My last slide, next slide, is a set of resources. Next slide, please. Yep.
Okay.
Back. Sorry, back one.
Yeah. Sabrina, you were freezing. So, so I think we have you back. So thank you so much. That was great from both Jordan and Sabrina. I know there has been some wonderful chat, and I wanted to just maybe bring the conversation up a level to get some of the questions answered that people have. I think Patrick had a really nice summary. I just wanted to restate that. So I think there's some questions around for North Carolina. What's the cost estimate of implementing something like this for the state? And I will just say that our next meeting, we're going to talk about financing, and I think we can sort of get into those details in the third meeting. But the other questions are about, so what's the impact on the number of uninsured covered and the extent to which each option reduces that number, and where is each option working best that there is a period of time to access? So what are the best practices for each option? So maybe we can focus on number 2 and number 3 for right now and just hold that cost question until our third meeting, if that's okay. Jordan, do you want to comment first and then Sabrina?
Sure. So as far as the number of uninsured covered, I mean, I think that it would just depend on, where, when we actually set up if we were to set up something like this, where, where would we target a lot of the restructured subsidies? So I think that one would just, we nail down that as we, came to a more clear understanding of what our waiver and application would look like. And in terms of where each option was working best, I think Maryland has a really good reinsurance program as well as Wisconsin that they were implemented in early. And then, like I said, our neighbor to the south, Georgia, just had one, so we can, watch and see how that one gets up and running. I'll turn it over to Sabrina if she wants to add anything else.
Yeah, I mean, I think it's important to be clear that like a reinsurance program absolutely can help people who do not qualify for the ACA subsidies find a more affordable insurance option. But if you want to target where most of your uninsured are, it's probably not in the population above 400% FPL. So some states have looked at doing both a reinsurance option as well as some state-funded subsidies for the under 400 population so that they can really try to get those eligible uninsured.
Great, thank you. Go ahead.
Can I just make a quick comment? In North Carolina, a little bit over 85% of the ACA population are subsidized, actually heavily subsidized. So I'm not too sure that the reinsurance option would be viable. I mean, one of the concerns we have, and by the way, we currently today provide coverage to over 90% of the ACA population here in the state. And one of the concerns we have is the fact that if 85, 86% are subsidized, and this was before COVID, right? What is that going to mean going forward? That probably is going to mean that they're going to fall off, right? And then end up in the uninsured pool, or at least getting closer to 150, 133, even 100% of the FPL, which is why, expansion, is a lever that must be, seriously considered to ensure that we cover the coverage gap. So can you just speak to that for a second? Because maybe we have a little bit of a different dynamic here in North Carolina.
Well, yeah, I mean, I think you're certainly right. And, the reinsurance program, I think can, certainly help some that, have, they can't afford their health insurance or struggle to afford their health insurance premiums. And, the constant rising cost of healthcare in our state. I mean, this is what, we want to try to drive down. So while it may not help, a lot of the folks that are under that number, I think it would have wide benefits, and we can, hopefully create a more robust health insurance market in the state. I think that's the main goal.
Yeah, and I think it's not an either or question, right? Most of the states, I believe, that have implemented a reinsurance program also have implemented Medicaid expansion.
Okay. That makes sense. Yeah, thank you.
Great. I wanted to also circle back. There's a number of questions about AHPs and wanted to make sure we get to those questions as well. There was a question, which I think Sabrina, you partially answered in the prior session about, do AHPs result in coverage for the uninsured, or does it shift coverage from the private insurance to the AHP?
Well, it's a great question. I don't know that there's great data documenting that AHPs do much to increase insurance among the uninsured. What AHPs can do is lower premiums for small employers and individuals who have a generally healthier risk profile, because essentially the way it works is the ACA has rating rules that limit the amount that insurance companies can charge higher premiums based on your health status. So if they can charge a higher amount to a sicker person and a lesser amount to a healthier person, it can lower premiums for those healthier folks. So to that extent, it could bring more people into the pool. On the other hand, it also means that it increases premiums for those with a sicker health profile.
And Jordan, do you have anything to add on that?
Yeah, I mean, I just think, that certainly may be the case in some situations, but I think what, the benefits we need to look at association health plans are that a lot of folks just don't have any options at all. And so, extending this other choice to them, allowing businesses more opportunities to pool risk together. I mean, I think that can only benefit if the other option is no insurance.
Okay, thanks. I want to be sure because there were so many questions in the chat, and please just go ahead and call out if you have a question on reinsurance or association health plans now that you want to get answered. Raise your hand or just go ahead and start speaking if I don't see you. I'm looking to see. I don't see any. One thing I will note that we talked about the, go ahead, Patrick. Yes, you're
just a comment. I hope we will stay focused. I think all of these options have some excellent potential benefits, but I hope in particular we'll stay focused as we are on the number of uninsured and how the extent to which all these different options in combination help us lower that $1.3 million or 1.3 million people number.
Yeah, and I was going to mention at the top of the hour, when we talked about the 1.2 million, the graphic showed, I think the vast majority of those individuals were at 250% of the federal poverty level or lower. So they are lower income folks that are uninsured. And so just how, for you all to think about as a group, if you're going to focus on that population, how does sort of the combination of all the different ideas that you've been talking about today, how does that fit in to make sure you get sort of addressing their coverage needs, which, if those were folks on the exchanges between 100 and 250%, they would be subsidized, for example. And then there's the coverage gap for those that are underneath. So other questions or thoughts from folks? I know we want to get to our behavioral health services panel and we're running late, but I don't want to leave them if there's a burning question on either AHPs or reinsurance. Last opportunity. I'm sure Jordan and Sabrina won't mind following up with questions after the fact, though, if you have any. So, okay. All right, well, thank you, Jordan and Sabrina. Those were excellent presentations, very informative on a complex topic. You packed in a lot in a short amount of time. So we're going to move on now to talk about increasing access to and coverage of behavioral health services. And we have a great lineup. We're going to try to do this efficiently because I know we're running short on time. But the good news is we had some time at the end for discussion. You all have been so interactive We're going to shorten that up so we will be able to have a full discussion on behavioral health, because I know it's of such importance to all of you on this council. So we're going to start with Cody Kinsley, who's the Deputy Secretary for Behavioral Health and Intellectual and Developmental Disabilities at North Carolina DHHS. So Cody, I will turn to you.
Thank you so much, and it's a pleasure to be here with all of you today. I will keep my slides short and look forward to the conversation later. So we'll move on to the next slide. So just to outline some of the numbers, we serve our behavioral health and IDD populations through our LME MCO infrastructure in North Carolina that many, if not all of you, are familiar with. Of the 1.8 million people that have Medicaid, 280,000 Medicaid beneficiaries received some sort of behavioral health or IDD service in fiscal year 2020. Of the roughly 1.2 million people that are uninsured, 106,000 received some sort of behavioral health or IDD service during that period of time. So you can see that the penetration as far as services on the uninsured side is less than 10% of individuals. We know from national studies that roughly 1 in 5 people who have a mental health or substance use disorder need in North Carolina are not getting service. And you'll see here in a moment when I highlight the types of services that are providing that really the bulk of our mental health services are focused on the crisis system in providing that sort of last chance opportunity when something is to the point of a truly emergent and critical care moment. So let me break down a little bit about those key services that are funded. So obviously, no individual has just one type of service need. We have highlighted the preponderance of the services, but often individuals get multiple types of services in this array. So these buckets are shaped in that way. So for mental health in state fiscal year 1920, we spent over $132 million of state funding and some of our federal block grant funding, but the bulk of these are state funds to serve 68,000 individuals that were uninsured. The top services that were funded were inpatient hospital, outpatient services, some residential support, and assertive community assertive community treatment. Really, for those of you that are familiar with these types of services, these are our most expensive, high dollar services for our most complex individuals. So individuals that are likely experiencing chronic or persistent homelessness, individuals with highly complex needs. So they're often bouncing between being inpatient and being in some sort of high fidelity wrap scenario where we're wrapping as much services around them as we can with our state funds. Similar with substance use disorder, $109 million on 39,000 individuals. This, of course, is a portion of this is related to our opioid use disorder work in response to the opioid epidemic. And I think that the same sorts of services around crisis and then opioid treatment program, which is quite expensive. And the last bucket is a little different than the prior two in the types of services. And these are for our individuals with an intellectual or developmental disability or a traumatic brain injury, but roughly $60 million on what is a much smaller number of people because of the higher cost. I will say that the bulk of these services are primarily these individuals are in two categories. They're either A, on the waiting list for services through Medicaid. And so we're providing state funds to wrap additional services around those folks who are maybe not getting what they would get if they had an innovation waiver slot that I believe my colleague Dave Richard has spoken about. And then also there are some number of people in this bucket who have commercial insurance who are potentially underinsured and not getting additional services and need them as part of their habilitative supports. These are day activities, residential supports, some other sort of day programming that are often not paid for, but are part of a meaningful day experience for people. So that in a sum is where those services are. I just wanted to indicate a little bit about how the system is performing and need. I think the top line from the last slide is really that for mental health and substance use disorder in particular, we are exhausting our state funds every year and really keeping people at that point of crisis. We don't have the resources to get upstream. We know in behavioral health in particular that not only is prevention so critical, because every time someone has a crisis, the ability to restore them back to functionality gets less and less. So prevention is critical. And we also know that physical health care is critical as well, not to mention social determinants of health, right? If someone is struggling with housing or food security, it is very hard to stabilize their chronic or persistent mental illness or whatever their severe needs are. And so unfortunately, because we have to sustain at that point of crisis, we have not had the resources to invest in those upstream things that would be lower cost, but higher value over time for these individuals. So you can see here that unfortunately, oh, I'm not quite, sorry. You can see here with this slide that while we're not, while we're already kind of in a hole as far as trying to serve people, we weren't getting to everybody that was touched. We also weren't getting the services everybody needs for true prevention and recovery. The task ahead of us is getting harder. Over the last several months, we've seen with the COVID pandemic an impact on people's mental health and wellness that's going to be lasting with us for some time. This is quite serious, and I'm very worried about how we're going to be able to not to just keep these people out of crisis, let alone push them towards recovery in the current way our system is strapped with a number of people that are not covered. Some specific statistics is that during this past several month period, we have seen a drop of 19% of people going to the emergency departments. However, at the same time, we've seen a 24% increase in opioid overdose ED visits. This is after years of decline because of the governor's leadership around the opioid action plan and the partnership of many of you on this gathering. And unfortunately, we've quickly rebounded with overdoses at that period of time. At the same moment of those increase of opioid overdoses, we've seen a threefold increase in reports of anxiety and depression among North Carolinians over this same period of time in the prior years. We've seen an increase in the amount of time it takes for people to get into our state psychiatric hospitals, which provide the highest level of most complex care in our state, going from 145 hours to 185 hours. Those are people that are often then waiting in emergency departments and creating costs for local hospitals that are not covered. This is particularly true for children. We have a big gap in the level of care that children can receive. Again, often our services on the state funded side are really focused on that crisis moment, and it's hard for us to get upstream to fund things that would stabilize and prevent those needs that would make the system perform overall. This last statistic, which has been in the news, some about a 91% increase in involuntary commitment. Again, there are some questions about the validity of that statistic. There's a hard measurement around court records, but the general point here is that it is up, and I think indicative of the need of crisis services in the state, and moreover than crisis services, prevention and making mental health services just a robust core part of primary care, if you will. So I think that's a nutshell. There's a few appendix slides that I'll leave you with that track on these statistics, but welcome any questions as we move into discussion down the road.
Great, and I might just pause for a moment because that was some great information. Thank you, Cody. If anyone has any sort of burning questions on what Cody just presented, please just raise your hand. I don't see any. Okay.
I do have
All right.
one, Kimmy.
Oh, yes. Go ahead, Senator. Yes, Senator Robinson, go ahead.
Yeah, Cody, do we have any data on the breakdown for that young adult age, like the 18 to 30, or do we have any, a lot of those kids are home with adult parents who may not be insured, is my concern, and can't access care. So, and I know that based on college age and other folks I'm hearing and seeing a lot of that, and parents exacerbate. Do we have any data on that age group in terms of the same data you gave in terms of opioid use or lack of access to care? Do we have anything in that area?
Senator, thank you for the question, and absolutely, I can follow up and provide to the council a breakdown of some of these statistics based off age, and you can see where that utilization pattern is. Right off the top of my head, I know that in that statistic where we saw a threefold increase of anxiety and depression, the leading cohort that expressed that concern were our younger populations.
Okay.
Which I thought was particularly moving in that while this virus has been so impactful of older generations, it has been the anxiety in that group, which again, I think seeds a level of uncertainty. I believe that, you know, COVID has impacted or, you know, created a traumatic experience for a generation of children. And I think that we also have to double down on thinking about how we not only provide preventative care, but try to restore folks towards resiliency as we move forward.
Thank you. Okay.
Just Representative Cunningham, Cody, I've worked with you on several issues with adolescents being in the emergency room departments for sometimes upward of almost 6 months with issues of bed placement for them. And I would like to see some analysis or some side by side so that we know the location where they're staying in these EDs too long and what is the preference in going forward as looking at the option of some crisis intervention regional sites, which some of the other states have done to decrease that issue and get the individuals back into their, you know, setting instead of having to remain in what is not appropriate setting for them.
Representative Cunningham, that's a great point. And I know we've talked about this a bit, but you know, the average child in North Carolina will wait 4.5 months to see a child psychiatrist. Yet the number of uninsured children, while rising, is still relatively low compared to the number of uninsured adults. And so I think we have serious stability issues in our basic prevention and access network for children around North Carolina. I think that's particularly challenging for our DSS involved children in higher levels of need. And again, I go back to this, while particularly true in adults, even more true for children, is that the bulk of our service array and our state funded safety net has really been geared only towards that point of crisis. And it's kind of like, you know, the old adage, if I'm only focused on pulling people out of the river and not focused before keeping people from jumping in the river, you know, the task gets harder and harder. So while we have some big system redesign efforts to do, we still have to continue to invest in earlier prevention work with children just as much as those crisis pieces. But we have to do all things at all times, of course.
Hey, Cody, it's today, but doesn't the data suggest that for those children that are in integrated systems of care, the numbers are much better, right? In terms of, you know, prevention, well, having access, right? Prevention, and then, you know, outcomes.
Yeah, absolutely. I mean, I think that, you know, but for behavioral health in particular, I think, you know, and I think part of our vision and transformation overall is really wrapping back into an integrated system of care and having the right levers that push that access happening more quickly as identified and referred from primary care, et cetera. So the data does suggest that that is an improvement, but I think that that also pushes the networks in a different way.
Yeah, so again, you know, all roads always lead back to coverage at the end of the day.
Yes, sir.
Thank you.
Okay. All right. I want to thank you, Cody. And those were some good questions. I want to turn now to Margaret Weller-Stargell, who's president and CEO of Coastal Horizon Center, to provide her perspective. I see her on my screen. So go ahead, Margaret.
Good afternoon, and thank you, Hemi, for the opportunity to speak with everyone this afternoon. I appreciate the opportunity to talk with you a bit about Coastal Horizons, which is based in Wilmington. We are a private, nonprofit, nationally accredited organization that I'm proud to say is celebrating 50 years in operation. It started out as a substance use treatment program with approximately 5 staff, serving New Hanover County only. And today we provide a multitude of services in 57 counties in central and eastern North Carolina and employ a little over 600 employees. Services include, but are not limited to, behavioral health, primary care, justice services, and crisis intervention services, which includes a licensed foster care youth shelter, as well as a rape crisis center. Our recent dramatic growth in the past 5 to 10 years has been in the development and expansion of our child and family services, which includes Clinical Latina, which is a program that we have to provide comprehensive behavioral health services to Latinx children and families in New Hanover and Pender counties. Our mission is to promote healthier lives, stronger families, and safer communities by providing a broad range of effective and evidence-based services. Our philosophy is, and it always has been, that anyone walking through our doors in need of help will be helped. I know we talked some about behavioral health services and mental health services, and I hesitate or pause a bit when I say this because I want to talk a little bit for a moment about medication-assisted treatment and how that ties in, as Cody was just speaking about, the opioid epidemic. Coastal Horizons is often known and referred to as an MAT provider only, and that's really just not true. So I want to get that miscommunication out of the way, although I will spend some time talking about it. We've been doing medication-assisted treatment since the early 90s. In fact, we started our first medication-assisted treatment program in October of 1990. And it's a program that is critically important when we talk about those dealing with substance use disorders. And I often compare it to other illnesses. For example, if someone is diabetic, the goal obviously is if they come in and to see a doctor and they're diagnosed as having diabetes, the goal is to look at how can we change diet? How can we get you on a better exercise routine so that you don't have to go on medications, you don't have to be on insulin? Well, for a number of people, that is not something that works, that they have to be on medications as a diabetic. Why is it, or should it be any differently for someone who's dealing with a substance use disorder? And that's why medication-assisted treatment is important. And as you look at the opioid epidemic, again, as Cody mentioned earlier, and the rise in the numbers, it is critically important that we have that service and program available. One of the other things that I wanted to mention about what we do at Coastal Horizons is in 2008, we saw that we were doing behavioral health services, but we also knew that the behavioral health issues were impacting their physical issues. So we started integrated care in 2008. We saw a decline in the number of ED visits, and we did that through a partnership with the hospital here to be able to see how we could keep those individuals from going into the emergency department or emergency room. And we've been able to maintain that service in a large degree for those clients. In our Wilmington office, you can be seen for behavioral health in one building and cross over to the other building and be seen for primary care. And treating the whole person, we have learned, is critically important. But who are the individuals that we're seeing and how are they covered? When we talk about those who are uninsured, about 3% of those that we see are in substance use and mental health or behavioral health services, either have commercial insurance or Medicare. 77% are uninsured, and only 20% with substance use have Medicaid. As Dave mentioned earlier, if we have someone in services and they lose their children because of a substance use disorder, then they lose their Medicaid. Mental health services is slightly different in that with adults, we have 42% that are uninsured and 58% that are on Medicaid. But again, when we talk about the number of individuals that we see in substance use services, only 20% have Medicaid. As we talk about the opioid epidemic, we have an opioid treatment program, which before the pandemic, we were seeing daily about 472 patients. We're now over 600 patients that we're seeing in our OTP program. So as Cody talks about the 24% increase, we're certainly seeing that at Coastal Horizons as well. So there clearly is a lack of parity for substance use and mental health disorders. And again, I want to stress the lack of coverage for those who have substance use disorders. And I hope that we'll spend some time looking at that and how we can improve that. As I said earlier, at Coastal Horizons, our philosophy is that we want to be able to help anyone walking through our doors. But are the current funding mechanisms adequate? When only 20% of those we serve for substance use disorder are Medicaid eligible and otherwise uninsured, without state dollars, the answer is no. And the state dollars are already strained and pulled, as we all know. I'm certain Medicaid expansion would allow everyone to look at how we could reinvest state dollars, and it would allow us as providers to adequately treat those most vulnerable individuals who have a substance use addiction. If we are to continue to successfully provide vital and life-saving access to mental health and substance use treatment, behavioral health providers and those that we serve must have better access. I hope North Carolina will consider an approved Medicaid expansion for our state. I'm going to say that again. I hope North Carolina will consider an approved Medicaid expansion for our state. It is my hope that of the 12 remaining states that are without it, we'll move forward and be a beacon for the South. Thank you.
Thank you, Margaret. I might turn to Gene Woods to make sure that we have time for his comments. So Gene Woods, President and CEO of Atrium Health. Take it away.
Thank you. And also just thank you for making this a priority on our agenda. I think every single speaker today talked about mental health, and that's partly because 1 out of 5 in the country, and most of us know somebody that has mental health. So I think it's topical every day. I think in North Carolina, 90 counties don't have a mental health provider shortage, and either geographically or population based. And there's a company that, or the organization that ranks states by mental health. It's called Mental Health America, and by access of care and also rate of illness for children. We've been talking a lot about children. North Carolina ranks 44 out of 50 states, so we're really near the bottom. And you've heard some of the challenges today. To tell you a little bit about Atrium Health, we are actually on the front line of behavioral health and have been for quite some time. We run 2 hospitals, 2 behavioral health hospitals for a total of 264 beds. We have about 1,000 people that are dedicated to behavioral health, 98 psychiatrists, 34 advanced practice nurses that are specifically trained in mental illness. We have the only dedicated psychiatric emergency room in the Southeast. Last year, we cared for 135,000 outpatients. And then we also have invested significantly in telehealth. So if you go into one of our primary health doctor's offices today, and they ask you some questions, and if you have a behavioral health need, then we actually beam one of the 98 psychiatrists that we have or the advanced practice nurses into that physician's office, so that by the time that patient leaves, they're fully assessed, they can get the meds that they need and so forth. So we've made a significant investment in mental health and behavioral health. It costs us about, we subsidize that about $60 million every single year. Frankly, we could double that and still not come close to meeting the needs. So I really do believe that expanding coverage, because most of the people that we treat do not have coverage, is one way to really deal with this issue. Notwithstanding all of those resources and everything that I just mentioned, today or this week, we'll have upwards of 100 patients in our emergency rooms that don't belong in the emergency rooms, sometimes for days at a time waiting for placement. And I'll give you an example. Yesterday, I started very early, rounded at 4 of our hospitals. So I hit all of our COVID units and spoke to the nurses who are really, and doctors and caregivers are working really hard because we're really concerned about January. But I also toured at all of our emergency rooms. And so just to kind of give you a little glimpse, I was in Pineville, rounding, actually looking at a overflow emergency room area for COVID. And one of our patients who had been there in the emergency room for 4 days got extraordinarily combative. It was a mental health patient. And so we had not one, not two, but 3 of our officers had to go into that room to help restrain the patient. And we also had about 8 caregivers, nurses, doctors, respiratory therapists that also had to be in the room to care for the patient's healthcare needs. So at a time that we're fighting COVID, we have upwards of 100 patients for days and days and days at a time in an emergency room for lack of placement. So we see this every single day. When I was speaking to those nurses and I told them that I was coming to have this conversation to a T, they said, could you please raise these issues because we need help now. So we're here to talk, obviously, as much as anything, hopefully, about solutions. My team has prepared a pretty extensive list of short-term and long-term recommendations that we'll be sending after this call and hopefully can be included in some of the minutes from this meeting. But let me just share a few of them. One is we really need, and we would support timely access and investments in state behavioral health hospitals. I think there's only 2 hospitals right now throughout the state. And the priority right now is those forensic cases that come through the courts. So we as many times have patients in our emergency rooms that are there for extreme violence or sexual aggressive patients as well, that we have to provide one-to-one care. And so because of the priority, understandably, because of the lack of resources, those patients sit in our facilities and they should be somewhere else. And part of my concern regarding that is if you think about violence against nurses and healthcare workers, it's at an all-time high. 60% of caregivers have been the subject of violence, and sometimes in those situations, it's because they don't have enough resources to deal with patients, including mental health patients. So we do need a plan for a short-term and a long-term plan for how we're going to deal the lack of actually inpatient capacity to meet the need. The second thing I would highlight is that we need to establish interim solutions for foster care. So for those of us that have kids, the last thing we would want them to do is go to an emergency room, let alone make that their home. This year, we had a 10-year-old child who was in our psychiatric ED for more than 179 days, awaiting appropriate foster placement. And we know that Medicaid only covers 30 hours of care. So our employees, their hearts are absolutely broken by this case. And we've reached out to the LME. They've made it clear that it's not their job to secure foster care placement. So we're really dealing with this one patient at a time. And those are patients who've really literally been abandoned at our front door. So we need immediately to develop an interim placement solution for kids, adolescents that are waiting too long in hospitals. And we've also identified in Mecklenburg County that both Thompson Child and Family and also Alexander Youth Network have expressed a willingness to participate. So I think it's going to be important to gather those folks that are willing to do something about this and then come up with recommended solutions so that we can deal with this issue that we're facing right now as I speak. The other thing I would say is, the third one I would say is a 72-hour authorization limit. So we should have at least a specified time by which these patients need to have placement. We have another patient who's been with us for 187 days. So a child, 187 days. Our clinicians have said that he is a victim of extensive sexual abuse and also demonstrates sexually reactive behaviors, and he's in desperate need of psychiatric residential care. We have been told that the patient does not meet a definition of aggression and therefore would not qualify for the next level of care. So we have a system that's clearly broken. And I think we've had a number of conversations over the years about how to fix it. And I'm really hoping that out of this conversation, coverage is part of the solution, but we really need a much more comprehensive focus on this that includes all of us on this call, because this is something that we're dealing with. And I saw yesterday every single day. So I think we are one of the largest providers of mental health services in the state. We're committed and willing to work with whoever we need to deal with this. I'm here on behalf of my caregivers, those that work in our behavioral health hospitals, those nurses, doctors, everybody who deals with it, because we can't have our emergency rooms be the default for children and adults when they have no other place to go. So the system is clearly broken, but I think that I'm hopeful that this group working together can begin to come up with some really real solutions to move this forward. And like I said, we'll be submitting our list of recommendations, both short-term, mid-term, and long-terms, so that we can digest that and hopefully do something about it going forward. Thank you.
Thank you, Gene. That was excellent. And thank you to all three presenters on the behavioral health topic. I know we're running short on time, so I'm going to turn it to Mark McClellan. But just to wrap up a couple of things, just from this incredible discussion, just a reminder, Elaine Chien, who is hard at work planning all of these meetings for you all, she did send out that survey. If you haven't responded to the survey, please follow up with her. We will keep it open for as long as you need to just give us your responses so we can add it to the list of things that you all want to talk about. I also wanted to let you all know that we are summarizing the meeting and so can provide high-level points of a summary back to you all on the council. So that is something we can do for you as well. And those of you that have any resources that you want to share, like Jean just mentioned, please send them to Elaine and we'll be collating them for the group so that you all can have them at your disposal. So thanks very much. And with that, I'm going to turn it over to Mark McClellan.
Great. Thanks very much, Amy. And as you have just been hearing, although this session is titled Discussion Next Steps, we've had a lot of great discussion along the way today. And we're going to be doing some further work on the next steps by synthesizing what we've heard at this meeting, getting some more input from you. And thanks to those who have already responded to the survey that Amy mentioned. So having not very much time here, I think, is okay in the overall process. So I do want to thank the governor and the council for their participation throughout the day, and for many of the council members who spoke on various topics eloquently and with a lot of heart as well. We truly appreciate all of your engagement. We have a lot of different viewpoints represented here, and it's great to see everyone working together. We heard about the agreement that additional steps on access and coverage are needed, with some creative and thoughtful ideas about how and whether different initiatives might be able to work together to get a better result that makes sense in North Carolina. And this work is perhaps more timely because of the context of the COVID-19 pandemic. We've talked about the high cost of healthcare and costs of uninsured on employers today, especially small businesses, that's been aggravated by the economic impacts of the pandemic. And we've also heard about the importance of addressing issues related to access and coverage because of the challenges ahead for long-term recovery from COVID-19 from a health standpoint for North Carolinians, not just the physical health problems that are lingering, but particularly mental health and the very concerning upturns we've seen in substance use disorders. We heard about a range of initiatives and topics that can help: association health plans, Medicaid expansion, reinsurance, value-based care initiatives, telehealth, digital health. And also we heard about a lot of interest in addressing the financial implications of these various approaches. And I just want to emphasize that we're going to be covering the financial implications as a major focus in depth in our third meeting. So the discussion we had today added a lot to that pre-meeting survey. We want to hear more from you to make sure we're not missing any key ideas here. I just would add that the survey also highlighted issues around coverage in rural areas, access to primary care, and the need for, again, additional information about the outcome, consequences, and the financial implications associated with these policy reforms and how to fund them. So that's all ahead in our further work. Before we end, let me just ask, we have a few minutes. Would the council members like to raise any other final questions or issues as we look forward to our future work, or any feedback from today? And again, you can also send those questions and feedback through email and through your responses to the survey. But let me just pause here. Any final thoughts from any of the council members?
This is Representative Adcock. Gosh, this has been an overwhelming day. I feel like I've just sat in a room with a patient telling me a very complicated personal and family and past medical history. And now we got to come up with a treatment plan. And so as I've listened to this, I just want to reiterate, whoever the smart person in the group was who said this, there's not going to be one thing that's going to address this whole problem. It's a complicated problem. It's going to take a market basket approach to solving it. And so what I think would be helpful to the group to see is what combination of strategies and solutions could not just chip away, but make a substantial difference in our number of uninsured across the board, not just those who are above 400% of poverty level, but those who are actually below. And what combination of things, and then of course the price tag for that. So those are just my initial thoughts. And I just thank all the presenters today, and particularly appreciated the comments of everyone.
Great. Thanks, Representative Adcock.
This is Representative Cunningham, and I wanted to make my final remark before I get off. One of the things that also I'm very much interested in is the healthcare disparities. Even though we talk about each one of these items, mental health assets as well as physical assets, we still have the aspect of individuals that need those same services and may not be getting those services because of healthcare disparities. And I would like for us also to be inclusive when we're discussing these issues as we're going forward, because you know, I've been there and I know the experience of asking for a particular service that someone may qualify for, but they're not in line to receive that services based on whatever. So the healthcare disparity certainly plays a role in people getting mental health and behavioral health services, as well as their physical health services.
Yeah, really significant. Thank you, Representative Cunningham. I appreciate the point about disparities.
So this is Senator Robinson, and I wanted to make a final comment too. And I've been in between other Zooms, so I'm in and out on you, but I'm listening the whole time. At first, I want to say I really appreciate the discussion, and just say to Andy and Dale, the HPs have brought more information to me, and I think that's one to be included in terms of the discussions. But all of these options, we need to look at what they offer, what the population is, how does it target the uninsured, what are those costs, both to the individual as well as the state. So we can look at how do we address the healthcare disparities, because that's what it is. We don't offer preventive health care for these same folks who are getting sick. They couldn't go and get it earlier. Now they're getting sicker, and it's hurting you, the employers, because they can't come to work. It's hurting their families, and it is hurting us as a state. So I'd like to, in addition to the other representatives, see all of those in terms of the impact. But I really appreciate the information, and I have a whole lot of questions, you can see, but it's about informed decisions and trying to help us to move. We got to do better than this. We should not be like this in North Carolina. We're a better state, so we've got to do better. So I appreciate all of you. Thank you.
Thank you, Senator. Any other final comments? We have a minute or two left. Great. Well, really appreciate all these further thoughts and guidance. In preparation for our next meeting, we'd like to ask the council to spend some time thinking about, just building on these last comments, about what might be included in the guiding principles that are related to our overall mission around access and coverage. That'll be the end product for the council. We still have more work to do, as you all laid out. This is a complex diagnosis challenge, and the treatment needs to be better planned as well. So we've got a lot of work to do in the next month to make progress on that, but we do want to keep our end goals in mind. During the next meeting, there's going to be an opportunity for the council members to discuss the considerations and the potential guiding principles for our report in small groups, and then report out to the wider group on their conversations. I just want to emphasize again that we don't necessarily expect everyone to come to complete consensus on specific ways of increasing access and coverage. And I do like this idea of a combination approach, expansion, reinsurance, association health plans, all the ideas that that we've talked about. It does, though, seem like there's some real potential for agreement, at least on some key end goals, like more people being covered, more affordable coverage, increased access, prioritizing addressing disparities and addressing rural community issues, and some specific directions to pursue in order to get there. Probably a combination of steps is what we're definitely taking away from this work together. So we very much appreciate the hard challenges of this work around improving access and coverage and doing it in a sustainable way. I also deeply appreciate the ability of this whole group to come together. The partnership, the bipartisanship that we're seeing in this process is just extremely helpful for having effective discussions and hopefully effective action together on these issues. As we wrap up, I just want to thank everyone as well for taking the time and effort on this overall effort. This continues to be, I know, a very challenging time in terms of our public health emergency and the pandemic response, with everyone working together around vaccination and also around improving access to new treatments like monoclonal antibodies to help us move beyond the pandemic. I'm hoping that spirit of working together effectively will continue to extend to the work that we're doing here in the council. So thank you all very much again for the time and effort, and happy holidays to everyone.